therapeutics and potentially integrate them into practice. Organized by Scientific Society of Arupadi Medical College, Vinayaka Mission Research Foundation. Now we are into Series 9 with the theme of Technology-Enabled Healthcare after completing 8 series successfully. Last week we had Dr. Matthew Cherian who unveiled the magic of interventional radiology. And today in Series 9, episode number 45, we are very close to Golden Jubilee. We have Dr. J Balachandar, Senior Professor of Cardiology, former Medical Superintendent, JIPMER, as resource person to explore a very important topic everyone would have faced, the sudden cardiac death, unravel the mysteries. Now I would like to invite our beloved Dean, Dr. P.F. Kotur, to give the opening remarks. Over to you, sir.
Yeah. Very good afternoon to all the participants over here. I take this opportunity of welcoming today's resource person, Dr. Balachandar, who probably attained the superannuation from JIPMER, So he may, I don't know whether he has visited the Arupadi during his tenure. And I take this opportunity of welcoming our beloved Professor Seturaman sir, who is just now logged in from Malaysia. And I welcome all our medical director, research, and our Dean HPE, our DMS, who is hosting the ceremony, and all of the other participants. And take this opportunity of welcoming on behalf of our Honorable Chancellor and the Board of Management and the University and at large to this 45th episode. I was telling that we are soon heading towards the Golden Jubilee celebration of the this platform, which was created during the COVID times. Now with the second wave and the things becoming more frightening than before, probably now we also look back. This platform has served more than what is expected to all the matter fidelity. This is what I can see, which is evident by the total number of participants and the people who will be looking forward to participate in this. And of course, I am also ex-cardiac anesthesiologist, and one or two thoughts on this. Ever since probably it was described, and this has remained cardiac death, a sudden cardiac death, probably till today is they continue to be a mystery. And what we know about the death cause, and in spite of so many advances in the techniques, gadgets, knowledge, everything, still rightly titled, the mysteries of the sudden cardiac death certainly will be disclosed by Dr. Balachandar, who has spent probably most of his career in treating the cardiac patients. So with these few thoughts, I think we once again take this opportunity of welcoming Dr. J Balachandar for this platform. Over to you, Dr. Deepa.
Thank you, sir. Now I'd like to invite our Director of Medical Research, Dr. Vishnu Bhatt, sir, to introduce the speaker of today's session, Dr. J Balachandar.
Good afternoon, our respected Dean, Dr. Kotur, Dr. Seturaman, Vice Chancellor, former Vice Chancellor of Balaji Vidyapith, Dr. Mahalakshmi, our Dean HPE, and all senior faculty members, Dr. Deepa, our Secretary. I am on behalf of Vinayaka Mission Research Foundation Management, and also on behalf of ABMC, welcome Dr. J Balachandar, who is a very close friend of mine. Actually, I know him more than 50 years plus because we joined JIPMER together. Then he finished together MBBS, MD. Then he went to Delhi for doing his DM cardiology. He was in GBPAN. Then he wanted to come back and serve the alma mater, so he was back in JIPMER. So since 1983, we are working as faculty. He has become the senior professor of cardiology and head of the department, and also became the medical superintendent, very popular medical superintendent. So the union leaders will go inside making a lot of noise, but they come out of his room smiling. So I called some of them and asked, You go with so much angry and making noise. You are now smiling. What happened inside? So they say that whatever we asked, he has agreed. He said, I have no problem. All you are telling is right and it will be done. So they are very happy and they come out. And he has been the fellow of various associations, fellow of electrophysiology, then fellow of College of Cardiology, echocardiology, intervention cardiology, any cardiology related association, he is fellow. Dr. Sitharaman, and he used to teach us electrocardiography earlier days with the old style, and he's also examiner for DNB, DM, all anywhere in India, any college you see there, he was examiner. He's also in the UPSC expert committee. He is in the selection committee of All India Institute of Medical Science and many other colleges. He has established the cardiology department in JIPMER, started the cardiology super specialty course. He also started that interventional cardiology and non-invasive cardiology setup in JIPMER. And to his credit, for last 33 years before his retirement, he had collaboration project with France and people who had cardiac rhythm abnormality and blocks. They used to get free pacemaker in JIPMER. I think he must have done in tens of thousands patients. This pacing must have been done at JIPMER. He has more than 270 publications, and he has written about 15 book chapters and many distinguished papers he has published. In addition to all his cardiology achievement, he is a great musician. He used to sing on every occasion. He used to sing, and we used to call him as Kishore Kumar of JIPMER. And Dr. Sethuraman also, you may not be knowing, he's an expert in drum. So he used to beat the drum and he used a music system. And it is very nice to hear him. He's a very good speaker in addition and a great human being. I never seen him getting angry in JIPMER. Whenever you talk to him, he'll be smiling. Whatever is the problem, whatever is the issue, you don't find him getting angry. So it is very balanced person. And thank you, Deepa, for giving me an opportunity to introduce my classmate. And thank you very much.
Thank you, sir,
Deepa, you can continue.
for introduction. Before we move on to the session, I have few announcements for the participants. The meeting is recorded for academic purpose, so please kindly mute yourself. Kindly post your queries in the chat box for the speaker so that it can be taken up for discussion at the end of the session. Over to the speaker, Dr. J Balachandar, sir. The screen is yours.
Okay. So, respected Dean Dr. Kotur, respected Dr. Bhatt, Dr. Mahalakshmi, the Secretary of the Scientific Society. First, let me pay my regards to Dr. Sethuraman. He's been my mentor, philosopher, guide, right from MBBS from 1966 onwards. In fact, I keep telling his son and my son had a fight. I said, "What is this? I have been friends with him for nearly 50 years, and you are fighting after being friends for just a few years." So, but anyway, he's been everything to me. I came back to JIPMER only because he was there at that time, and we thought we can develop the Department of Cardiology together. But of course, he took interest in education, and he had a lot of other interests. He had computer. He took computer when computer was not even established in the medical field, and then medical education. And today he's the top man of medical education. And so, with these regards, and let me start my first slide, please. I've had association with the AVMC, sir. I have visited this institute as part of the Pondicherry University inspection. I have visited your Salem, and of course, I had the thing of meeting your previous chancellor also, with whom I was associated for a few years. So it has been very close for AVMC for me for a long time, and of course, your super specialty hospital at Salem. So let me start about because the lecture is going to take a little time, but I'll keep it as general as possible since the audience has been told it's general. So a lot of stories I'll be telling. Next slide, please. So it's already been introduced what is sudden cardiac death, but the first documented is the Fidafides, or I don't know how you pronounce it. Some people say Fidafides, some people say Fidipides. From Marathon to Athens, he ran 42 kilometers and conveyed the news of the Greek victory and died suddenly. So that's why all marathon the things in Jipmer, we keep the ambulance, but keeping the ambulance alone is not enough because you won't be able to, when the sudden cardiac death occurs, next slide please, you don't require ambulance. What you require is immediate defibrillation. And this is very common. This has become very common. There are about 140, 150 people, sports people, who are absolutely normal and who die suddenly during football or during running. In fact, the 100 meters lady of the world champion, she died suddenly while running. Next slide. So you see, this sudden cardiac death occurs in healthy people. And one of the common terms which is used, which at least undergraduates and postgraduates should know, is this term called commotio cordis. Commotio cordis means that these people, you're not allowed to touch the football with your hand. So what do? You touch the football with the chest. And when the football hits on the chest, especially the goalkeeper or the others, it hits the chest at a time when it's a vulnerable period. Here I have marked in red the T wave, the apex of the T wave, which is called as the vulnerable period. And any impulse which comes on the vulnerable period will trigger off a ventricular fibrillation. Though it is quite rare, but this is called commotio cordis. It's a direct blow to the chest at a critical time will result in, next slide, will result in a rhythm which is totally chaotic, and this is ventricular fibrillation. You can see completely triggered off by an ectopic which falls on the vulnerable period of the T. We have taken advantage of this. We have taken advantage of this in producing ventricular fibrillation in normal people. Why do we produce ventricular fibrillation in normal people? To know whether our defibrillator works. So we give what is known as a T wave shock. I'll show you at the end. How do we give a shock onto a patient and produce? That's why they define electrophysiologists as people who produce ventricular tachycardia and ventricular fibrillation in normal people. So that is why this T wave on R wave or R&D phenomenon is a very important part to trigger off a sudden cardiac arrest or sudden cardiac death. Next slide, please. Next one. So the important thing is the training, and the presence of defibrillator is not that unless and until we know quickly how to use the defibrillator. Defibrillator should be available in all places, in sports grounds. Now it is there in most of the places, if you see, in metros, in railway stations, so the simple defibrillator is the one which can resuscitate and which can prevent sudden cardiac death to some extent. Next slide. Next one. So this is the man who fought against sudden cardiac death. He is actually from Poland. He ran because of Hitler from Poland, came to US, and he invented what is known as a defibrillator. His name is Michael Mirowski. And first he did it on the dog and then successfully implanted in 1967 the first defibrillator. And now the defibrillator has evolved tremendously from that, and lots of people have received defibrillator. And at Jipper also, in fact, at Jipper we were the second in India to implant a defibrillator after the All India Institute. And subsequently, I think they keep putting defibrillators for at least at the rate of at least 4 or 5 per week. And this is a new defibrillator called subcutaneous defibrillator. Instead of putting it inside the heart, you can just keep it under the skin and put the lead under the sternum. So it will defibrillate. Of course, it won't pace, but it will defibrillate and restore normal sinus rhythm. Next slide. So what is the definition of sudden cardiac death? The WHO has clearly said it is within 1 hour of symptom of rest. And the patient may have prodromes. He may have prodromes for a long time. Next slide. But his onset to the sudden cardiac death is up to 1 hour. So they have prodromes. They have arrhythmias, hypotension, chest pain, etc. But they will have a sudden collapse, loss of effective circulation, and loss of consciousness, and up to 1 hour. After that, it's a biological death will set in. So this is the chronology of sudden cardiac death, which has to be prevented. Next slide. So the problem is too much, because you find that there are most of the cardiac arrest will occur as the first clinically manifested event, and nothing can be done about it. And 25% of the victims have high risk markers. We can't identify who is going to do it. In fact, it is said that the person who is playing gambling in Las Vegas, he has a risk of sudden death, but he will survive because there is a defibrillator there. But a person walking on the streets of India or New York won't survive because there is no defibrillator available. So we don't know what causes what, but there is a high risk. Next slide. Next one, please. So you find that it is not a random event. And in fact, it kills more than 1,000 people a day, perhaps more than COVID. And it's one person every 90 seconds. The sudden cardiac death now has gone into the background because COVID has come into the forefront. But still, a lot of people have a sudden cardiac event. Next one. So you find that people, next slide. Even in there are situations in India where the annual incidence has been worked out roughly by Fortis Hospital at 0.55 per thousand, and the peak incidence is between 45 and 75 years. But the unfortunate thing is between 45 and 55, there is a huge risk. Next slide. So Dr. Hayagiri Rao from the Care Hospital in Hyderabad, he's done a study called the South Indian Study. It was published in International Journal, and he find that it occurs, that is about 47 or 50% were less than 60 years of age, and his results are, next slide. Come to the next slide, please. So he finds that it is younger, 5 to 8 years younger compared to the Western population. So that is a point which is a little difficult to understand why it occurs younger. Also because the mortality is totally unpredictable. Next slide. So you find that it is a big problem, the sudden cardiac death, in terms of, and these are all the conditions which are there for sudden cardiac. Normal heart is the most important problem of sudden cardiac death. If somebody has coronary atherosclerosis or a dilated cardiomyopathy or a hypertrophic cardiomyopathy or myocarditis, etc., or dissecting aneurysm, these are all expected that they can die suddenly, or conductive system disorders, etc. But the normal heart is the biggest problem, which gives rise to mystery, which still we are not able to unravel. And that is the mystery of sudden cardiac death. We'll just see what happens here. Next slide. So in the Framingham study, you know that coronary artery disease is associated with high risk in events. Even there are people who are younger than us, like 2 years younger. A person came from US, he belonged to Jipmer, and he died suddenly in Chennai. And it was coronary artery disease. So coronary artery disease, perhaps with LV dysfunction and the NIHA class, are powerful predictors of ischemic heart disease. Next slide. If the ejection fraction is less than 30%, it's understandable. It is. So don't look at the bottom line. This is taken from Meyerberg's study in New England Journal of Medicine. He explains it. But what is important is to look at the stable plaque, which becomes an unstable plaque and gives rise to a transient ischemia. So the myocardium cries immediately. So as soon as the muscle is devoid of blood, the myocardium cries. And the crying of the myocardium is ventricular fibrillation. And at that time, if a shock can be administered, then perhaps the patient can be saved. That is in the acute phase. In the chronic phase, it gets remolded. It goes to an ischemic cardiomyopathy and forms a scar, and still it can be a substrate for arrhythmias. So you have ischemic burden, you have hemodynamic fluctuations, autonomic variations which are important, and drugs and electrolytes. In fact, to tell you a story behind this, when I was training in Delhi, just 5 kilometers away, we were running a mobile coronary care unit. The patient had an inferior wall emboli and had a ventricular fibrillation. When I picked him up, in the ambulance, I gave a shock, and from ambulance to the hospital, we gave about 20 or 25 times shock. Took him to the coronary care unit, and I was doing a cut-down because those days we don't have facility for internal jugular puncture, etc. And a friend of mine, my colleague said, "This fellow is gone." The patient says, "Sir, please don't tell like this. Please do something to save me." That means he was conscious. After 25 shocks, he's still conscious. And so the beauty of defibrillation and possibility reviving is that the patient remains conscious at all. And so you have to be a little careful and try your level best for resuscitation. Next slide. So we have some biological models. The main biological models is the electrogenic theory. You have structure and you have function. And the structures are, of course, myocardial infarctions, which can give rise to problem. When the muscle is hypertrophy, like this is what happens in athletes. When the muscle is hypertrophy, then it can give rise to it can become arrhythmogenic in nature. So two things happen in athletes. One is myocardial edema and gross myocardial hypertrophy, and they form a substrate for sudden cardiac death. Next slide. So we come to the important causes or the risk factors of sudden cardiac death. Genetic factors are the most interesting, but they are rare. The coronary heart disease risk factors are the same as that for acute MI. You have arrhythmias, some interesting nutritional factors which are relevant to Pondicherry, psychosocial factors, and of course biomarkers. Next slide. The biomarkers will be for tomorrow because it's the genome biomarkers which will give you whether the patient is going to develop sudden cardiac death. Now, this is an important thing that there is, if patients take more polyunsaturated fatty acids, it's inversely associated with sudden cardiac death. So it is protective to sudden cardiac death. So heavy alcohol consumptions, more than 5 drinks per day is associated with sudden cardiac death. More important is atrial fibrillation. And that phenomenon is called as holiday heart syndrome because patients take alcohol binge on holidays and develop atrial fibrillation, but they can have sudden cardiac death. If patients take a high risk, so in addition to that, if patient takes light to moderate levels of alcohol, it may be protective. So alcohol is not totally harmful. In light, it protects. In heavy, it causes sudden cardiac death. Next slide. Psychosocial factors are also important, and you know that patients who are having psychosocial elements are at increased risk of sudden cardiac death. Next slide. And then we come to the triggers. The triggers are the autonomic changes, parasympathetic, sympathetic, electrolyte abnormalities. The substrate I've already mentioned. Electrolyte shifts are also important. All this will lead to VT, VF, asystole, electromechanical dissociation, and sudden cardiac death. The sudden cardiac death is quite unfortunate, whether it is for the surgeon or it is because after toiling with the patient for so many hours, if the patient has to die suddenly because of electrolyte imbalance or because of something else, it is really a sad state of affairs. Next slide. Now, these are again the factors like age, hypertension, diabetes, smoking, obesity, kidney disease, and of course, coronary heart disease and congestive heart failure. Those are all the triggers will give rise to sudden cardiac death. And these are seen in the majority of the population. So we have to be aware of what triggers a sudden cardiac death in them. Next slide. As opposed to this, next slide. Hypertrophic cardiomyopathy is a rare condition. Next slide, please. Sudden cardiac death is the most common cause of death in hypertrophic cardiomyopathy. This is actually commoner than what we think it is. It's 1 in 500 is the incidence. So it is a common cause of death in athletes under 35 years of age. I said hypertrophy is perhaps the cause. Next slide. And similarly, heart failure. This is the echocardiogram. It clearly shows you can detect it very easily. On the left side is normal. On the right side, you see the markedly thickened interventricular septum and the posterior wall, and as well as the glistening interventricular septum, which is characteristic of HOCM. Next slide. The heart failure is an important, as I said, 1/2 of all deaths of heart failure are due to arrhythmias. We treat heart failure, they keep coming to our OPD, we give them drugs, nothing happens to them, but their death is sudden because of ventricular dysfunction and arrhythmias. Next slide. When we come to, if you have to summarize what are all the things inside the heart, this slide summarizes everything. From the aortic, you have rupture, you have dissection, and of course, Marfan syndrome. The electrical abnormalities are these syndromes, which I'll just tell you a little bit about: Brugada, long QT syndrome, etc. And the miscellaneous. And then the ventricular causes are hypertrophic cardiomyopathy and some genetic abnormalities, which I shall briefly present for the postgraduate sake, because I always keep asking, even for MBBS as well as for postgraduates, what are these entities? Next slide. And coronary artery disease, which is the most important. So coronary artery abnormalities, hypertrophy, myocardial diseases, inflammatory, infiltrative diseases. See, sarcoid, which we thought is mainly multi-system disorder, sarcoid causes sudden cardiac death by ventricular tachycardia. Similarly, the electrophysiological abnormalities, and of course, Dr. Butt's field is a sudden infant death syndrome called SIDS, and sudden death syndrome in children, which is a very important cause of it. And funny thing is, it occurs in male babies. So people get more and more this thing, and they will protest outside. As Butt said, there'll be a lot of cases coming outside my room when I was MS, and you'll have to deal with them. Next slide. Next one, please. Now, these are genetic contributors. A few words about this. I won't go into big details. One interesting thing is called congenital long QT syndrome, and of course, short QT syndrome. The other one is called Brugada syndrome, and the third one is called catecholaminergic VT. And of course, there are drug-induced long QTs also, which can give rise to sudden cardiac death. And there was a lot of talk about hydroxychloroquine in COVID as a protective effect. And then everybody said it causes sudden cardiac death by simply prolonging the QT interval. Next slide. So what is this Brugada syndrome? Brugada syndrome is actually an inherited defect of the sodium channel, and the epicardial area of the right ventricle has a repolarization abnormality. It is rare, but it has to be recognized. Otherwise, in young people, it will lead to sudden cardiac death. Next slide. So you get the ventricular fibrillation, as you see here, and the ECG will show a characteristic abnormality which we have to discover, and that is the ST elevation, which is coved in V1 and V2. And if this does not occur, then we can give a drug called flecainide and produce this change and see whether they are prone to develop this sort of a ventricular fibrillation. Next slide. So that is about this Brugada syndrome. And the problem is that these patients will require implantable cardioverter defibrillator. You can see it on the right side, the ICD it's called. It has detected the ventricular fibrillation, which has occurred in Brugada, and it has given a shock and converted to normal sinus rhythm. This is what the ICD will do. Next slide. 400 milligrams of flecainide can produce this sort of a thing. Now, there are very interesting things like Setu is in the far, he's not really Far East, but he's in Malaysia. But in the Far East, you have what is known as sudden unexplained nocturnal death syndrome called SUNS. Most of them perhaps are rare, but whatever it is, it was called Bangan Gut in the Philippines, it was called Lai Thai in Thailand, and Pokuri in Japan. These are all young people, very young people who are typically males, and they die suddenly while they are sleeping. Next slide. We could not, the researchers could not find what are the causes of this sudden death, and the population has named them as voodoo death. Voodoo death means that they have been sort of isolated from the tribe. They have a sense of hopelessness. They have bradyarrhythmias. More important is that instead of sympathetic overactivity, these people have parasympathetic overactivity as a cause of sudden death. Next slide. So the mechanism of voodoo death is also there. So the long QT syndrome is a genetic syndrome. It is because it causes sudden fainting and cardiac death. Next slide. The interesting aspects of the long QT syndromes are, it is rare, but we have to look at it. So there are two syndromes which are taught even in undergraduate level. That is called as the Romanov-Watt syndrome and the Jarvis-Lang-Nielsen syndrome, the JLN syndrome, which is associated with congenital deafness, and the Romanov-Watt, which has no deafness. One is autosomal dominant, the Romanov-Watt, and the one with deafness is autosomal recessive. And of course, these are multiple choice questions in any of the PG entrance examination. Next slide. Next slide about the LQTS. This is the typical ECG of a LQTS syndrome. You can see how bizarre the T waves are and the prolonged QT, which may trigger off ventricular arrhythmias. Next slide. Next one. Now, this is interesting because the long QT has various types. There are, in fact, more than now 13, 14 types. But the interesting ones are that the first type of long QT syndrome is the patient dies suddenly during swimming or during exertion or during emotion. Sometimes even during singing, the patient has a sudden cardiac death. The second type called KCNH2, which is long QT2, there are auditory triggers like ringing of a telephone. There are people who have died suddenly just because the telephone was loud enough to ring. And sometimes it occurs in the postpartum period. And more common, and which is there in exclusively in male patients, is the LQT3, which occurs during sleep. Unfortunately, it occurs during sleep. So it is thought that even the sudden infant death syndrome is the type of long QT, although it is not found. But still, this is so much prevalent in males that sometimes the population where it is prevalent, the males will dress like females and then go to sleep. They think that if they dress like female and go to sleep, sudden death will not occur. It has been sort of ingrained in them. That is because it's exclusively found in males, the long QT3. Next slide. So that is about the long QT syndrome. Again, it is quite rare, but it has to be, you have to find and treat it because the treatment can be a defibrillator or you can use simple beta blockers, which can give rise to a long life in these people. And now they have done what is known as left cardiac sympathetic denervation. The anesthetists are able to do it by just injecting alcohol into the stellate ganglion percutaneously, or the surgeon can do it percutaneously also. It can be done, and you can help the QT to come down and patients to thrive. Next slide. Next one. So this is again an interesting thing. When we put the patient on treadmill, most of the times the treadmill is done by the technician. He doesn't see what is happening, and suddenly he will say some ectopics will come, and then the doctor will go and say, oh no, these ectopics are okay, it doesn't matter, it will come during every exercise or treadmill. But one thing which can occur, especially in younger individuals, is what is known as catecholaminergic polymorphic VT. It can occur suddenly during exercise, and this is a polymorphic, that means different shapes can occur. And this can occur in patients with normal QT intervals and patients without ischemic heart. It's got a very high family background. So when the patient has ectopics during exercise, we'll have to be careful and we'll have to know whether are we dealing with this arrhythmia called a CPVT. It is a marker for sudden cardiac death. Next slide. There is an entity in the heart. Now we have dealt with genetic syndrome. This is also a genetic syndrome, but it has got a structural abnormality. And this structural abnormality is fibrofatty replacement of the myocardium. And this is now goes under the term of ARVC, or arrhythmogenic right ventricular cardiomyopathy. This is in 3 phases. Early subclinical phase, where everything will be negative and the patient will go into sudden cardiac death. Nobody can do anything about it. Only autopsy may show that the right ventricle was, had fatty infiltration. The second is the RV abnormalities, which are obvious, but again, it need not have any clinical manifestation of RV dysfunction. The third is fibrofatty replacement with infiltration of the myocardium. Next slide. So this is now diagnosed with cardiac MR. Cardiac MR has come in a big way because it has helped the both for coronary artery disease, with myocardial infarction, etc. And one entity which can be picked up with a CMR or a cardiac MR is this fibrofatty infiltration. Next slide. So this is a arrhythmogenic right ventricular cardiomyopathy. This also can be picked up on the ECG. The ECG will show a wave which is known as epsilon wave, which is shown on top, and this can precipitate a very characteristic ventricular tachycardia, which has got a LVBB morphology, and with the right axis or a leftward axis, and this will occur from either from the RVOT or from what is known as a triangle of dysplasia. That means tricuspid valve, apex, and RVOT is called triangle of dysplasia. Next slide. This is quite amenable to treatment, and there are two important genetics. One is called as Naxos disease, which comes from the Greek island of Naxos, otherwise called as woolly hair, where there is palmoplantar keratoderma, and the second is called Carvajal. Carvajal syndrome does not have ARVC, only the ARVC is characteristic of Naxos disease. Why we are talking about this rare disorder is that this has resulted in development of genetics. Next slide. We'll come to this from the next slide onwards. Now, because this is a talk on technology, that means frontiers of. So, what are the technologies we have for sudden cardiac death? One is in assessing the risk, and that's the most important one. We use a thing called microvolt T-wave alternance, signal average ECG, TMT test, Holter monitoring, echocardiography, CMR, coronary angiography, EP studies, biomarkers, and genome-wide association studies. The GWAS has become a very big thing because GWAS is used in everything, because the next generation sequencing has come in a very big way. You have Illumina arrays for studying the genetic markers. Next slide. This is the equipment, simple equipment to detect T-wave alternates. T-wave alternates means every alternate beat. You can see below the T-wave is down, the little up, down, up. So you will be able to get this macro T-wave alternates. This will also detect micro T-wave alternates. Next slide. I think I have to be a little faster. Give time for the questions. Next slide. And this is the characteristic T-wave alternates in the long QT syndrome, which can precipitate VT. Next slide. So this equipment that was called Cambridge ECG or TMT machine. This is a simple ECG machine which is available everywhere, which is now it costs only about 60 to 80,000 rupees, and this can give rise to a signal averaged ECG. When we press signal averaged ECG, it will detect about 250 to 400 beats and identify the late potentials which occur after the QR. They're called after potentials. It will detect the after potentials, and these after potentials is as if the QRS comes and then there is a ringing artifact, just like a bell. After the ringing of the bell, you'll find that the sound comes for some time. So these are ringing artifacts are picked up. Next slide. And this is very important to diagnose this ARVD. Now we have implantable recorders, because Holter monitoring maximum you can do up to 48 hours. Sometimes you can extend to 72 hours. Most important is the patient cannot take bath till the electrodes are removed. But here you have implantable recorders which can be there for up to a year. You can just put it under the skin and you can monitor from outside, and you can see at what point of time the patient has ventricular tachycardia. Next slide. And then, of course, CT is most important. This is a very important CT, acute pulmonary embolism. You can see both the pulmonary arteries are full of clot. And this is an important thing in triaging in the casualty. Is it acute embolism? Is it acute dissection? Is it acute myocardial infarction? So CT is quite useful in that situation. Next slide. And then you have of course, this is the dissection which we had a patient. And remember, if the young patient comes with severe hypertension and left pleural effusion, that's the lesson we learned. It is likely to be a dissection with probably blood in the pleural effusion if there is no other cause. Next slide. And of course, coronary artery left main disease is the most important cause of sudden cardiac death, because the left main disease supplies a large area of the myocardium, and the myocardium will cry immediately when there is loss of blood. Next slide. So we come to the genetic, what is genetic genome-wide association studies in sudden cardiac death? And this has been done even in India, in the CSIR lab in Delhi. They do the genes called SCN5A, the KCN, and for all the some log QTs, and also they do ACE genes, and they do the gene which is plecofilin, which I told you is responsible for the arrhythmogenic right ventricular cardiomyopathy. Next slide. Next slide, please. And biomarkers are here to stay. Biomarkers for everything, from cancer down to everything. You have biomarkers of inflammation, neurohormonal regulation, hemodynamic properties, and of course, common biomarkers we now use is only NT-proBNP or BNP, and of course, the other things are slowly coming into, and of course, CRP is still being used. Others will still come into existence shortly, and it is predicted that acute myocardial infarction will be diagnosed by a biomarker in the beginning itself without any ECG, and an anti-inflammatory drug will be given, and patient can go home within the next 1 hour. Next slide. Next slide, please. Of course, electrophysiological studies are important. They are time consuming. They may not give that much of importance in sudden cardiac death. Next slide. As in other arrhythmias like supraventricular arrhythmias. But idiopathic VT is very important because that is the one which can be treated very well, like right ventricular outflow tract or bundle branch re-entry. And sometimes tetralogy of Fallot, this is the most unfortunate, that a patient gets operated for tetralogy of Fallot and post-operatively he has sudden cardiac death. So in order to prevent that, we can do a catheter ablation of the site. That means we can go into that site and destroy the focus, which is giving the, I'm not going into great details for radio frequency ablation. Next slide. And of course, the primary prevention episode protocols have been laid out by our society called Heart Rhythm Society, even the Indian Heart Rhythm Society, and they say refer to a heart rhythm specialist for, but then you see, heart rhythm specialist will only look at it from that point of view. He may not look at everything. And you must first go to a physician and see, for example, supposing it had been sarcoid, he may miss it. Supposing it is tuberculous myocarditis, he may miss. So it's important that everybody looks after and assesses the patient, not with regards to only his specialty, but the overall patient, so that you can detect and you can treat sudden cardiac death. Next slide. Now, one thing just for Dr. Bhatt, this is a sudden infant death syndrome. It occurs between 6 months of age and it's much more common in male. And it has got an incidence, of course, he will know much more than what is written here, of 1.2 deaths per 1,000 live births. But it has fallen, the incidence has fallen. I'm not sure whether he'll agree or not. It has come down to 0.57. The important thing about this sudden cardiac death in infants is the dysfunctional central respiratory control, which is both inherent and related to prematurity. But sometimes we have a primary cardiac mechanism which has been suggested. And as I said, it can be a SCN5A mutation. It can be accessory pathways which are rare in children, or it can be immature AV nodal or bundle branch cells. And all this can cause a sudden death in the infants. Sometimes what happens is appropriate sleep positions are, I don't know whether they still use it, that putting in prone or putting in supine, which is important, that only Dr. Bhatt can tell for the newborn to prevent the sudden cardiac death. Next slide. So what is the technology in therapy? Last few is First, you have to unravel the mystery, and the mystery you have to use all the technology which is available. Still, it can be a mystery. We have not unraveled, so I would say that maybe in about 20 to 30% of cases we can find out, but otherwise it's often difficult to find out why the patient has had a sudden cardiac arrest. Of course, the death means you can't do anything, but recovery from a death or recovery from the arrest. The problem is that even if it is EP guided, all the drugs cannot be tested, and the drugs which act in the lab will not act when you give them outside. So even if it is EP guided, many patients remain non-suppressible. Next slide. So what we do is that we have to put a implantable cardioverter defibrillator system, and the important thing about that is I've got only 1 minute I think left. So the next slide. Next one, please. The implantable defibrillator will prevent, what it does, it will prevent tachyarrhythmias from the atrium, it will prevent tachyarrhythmias from the ventricle, it will pace, so it will treat both bradycardia, pacing and sensing. Next slide. And this last is from our own ICD implantation. Next one. Where to test whether it will work or not. Of course, you are doing a patient when he is not having a tachycardia. So you have to induce a ventricular tachycardia and ventricular fibrillation. And here this is normal. Next one, next slide. So you give what is known as a T wave shock. If you give a T wave shock, then you will find that it will produce a ventricular fibrillation. If it doesn't happen, then you just pass electrical current through the heart. It's a little barbaric way of doing things, but still you have to do it. Then only you know whether the machine is acting or not. So you pass DC current through the heart. It is as if the fellow is putting his fingers into the plug point and switching it on, and it will produce ventricular fibrillation. There is zero pulse. Next. So the machine, next one, the machine will detect this. Next slide. Will detect this, give a shock as you see on left side, and convert it to normal sinus rhythm. This is the most important thing we have to test before sending the patient. Otherwise, you'd never know whether what you have implanted is really acting or not. Next slide. And this is, of course, the machine, the defibrillator, which we had implanted. I think now lots are being implanted in JIPMER every week. So that's about, next slide. So if the patient is required for a short time, doesn't require a permanent, now a new thing has come which is called as wearable defibrillator. Next slide. And this can be just worn and the patient can go around. And so last is the COVID-19 pandemic. I don't think I will deal much into it, but there are cardiac complications like hypotension, myocarditis, arrhythmias, and sudden cardiac death. Of course, you can't do much of diagnostic workup in COVID. Next slide. And the European Society of Cardiology has given the algorithm for the patient with COVID who comes to the emergency with cardiovascular symptoms, how to go about it. And this is the algorithm which we see. So thank you very much for your kind attention. I hope we have tried to unravel, but at the same time, I'm accepting that it's still a mystery.
Thank you, sir. It was such a elaborate session. We thought because sudden cardiac death is really a mystery for every clinician, and you have tried to explore it, the mystery behind this sudden cardiac death. Started with the sportsman, how the exact time which is responsible, like T wave, which you started with. It has, I think, everyone everyone became awake by the time you started this sportsman thing, and then you elaborated the causes, the triggers for this sudden cardiac death, with more emphasis on holiday heart syndrome, which can be prevented, I feel, and ventricular dysfunction, which is behind the cardiac death in cardiac failure patients, known cardiac failure patients, and few slides on long QT syndrome with genetics and the phenotypic reason for the long QT syndrome with the 3 type of variants of QT syndromes, and finally the latest innovation, wearable defibrillator, you have ended. I think it has. You have gone through the entire all the causes of the cardiac sudden cardiac death. Only I think you would have accomplished this within this stipulated time. You were able to complete this. Thank you, sir, once again for your elaborate discussion on such a very important topic for all the clinicians. So the is open for discussion. We have a few queries from the. We have a. First, should we train all the doctors in using
Yeah.
defibrillators? That is a question from Dr. Vishnu. But I think, yeah, we were thinking about that. Should all of us should know how to do defibrillation, because that is ultimately going to be the treatment for any cardiac death. We should be able to do it, right?
Actually,
Should be necessary. Right now, we are doing BLS and ACLS training for all the postgraduates in our college. So I think sir will be able to address this.
Actually, that's what, because the new curriculum itself is laying stress on the skill training, and it's very important to develop the skill on both BLS and ALS. And a skill, see, what happens is most of the time, of course, I don't blame the anesthetists, they only conduct it, but they will take a priority in intubation. That's very important, because first it was ABC, that is airway, breathing, etc. Now it has got changed to cardiac, so it has become CAB. But still, we have to get the cardiac in picture. As far as adult patients are concerned, it's important that we must get the heart going. And I have seen it myself when I went for to Calcutta. A patient of acute MI had a cardiac arrest in the casualty, was brought with resuscitation, but resuscitation was not effect, but straight away he was taken to the lab where he was done a primary angioplasty and he was safe. So unless the blood flows into the myocardium, the coronaries are blocked, nothing can be done. No resuscitation will save the patient. So we must establish the root cause and treat. That is more important. But of course, we must defibrillate, because the electrical event precedes all the mechanical event, and the electrical event can end in tragedy. So we must, in fact, I'll tell you one interesting story, because I have a little time. A patient went to the All India Institute. This is there in All India Institute records also, with chest pain. And of course, ECG showed ventricular ectopics. So he was put on a Holter monitoring, and he was sent away saying that he does not have any MI. On the way, while driving back in the car, he developed acute myocardial infarction. The heart fibrillated. He lost consciousness. The car hit the tree. The steering hit the chest, and sinus rhythm was restored. He regained consciousness. This is a fantastic example, because primary ventricular fibrillation can be just addressed by just giving a thump on the chest wall. It's called thump version. And this is everything was recorded by the Holter, and it's a fantastic story which we all tell, that the defibrillation training is really helpful, may save a lot of lives.
Thank you, sir. I think our Dean, sir, who have been a cardiac anesthetist for many decades, he would like to highlight something on sudden cardiac death. Before we move on to some more questions here.
Sir, not
Sir,
audible.
please unmute yourself, sir. Dean, sir, please unmute yourself.
Not audible.
Sir, please unmute yourself, sir.
To come to the screen and unmute. Sometimes it doesn't.
Yeah, because I was not able to unmute myself. I don't know what had happened. That's why I was showing you that way. Anyway, before I ask anything related to the specialty of cardiology or anything, I remember my undergraduate days in 1971-72, wherein we had a postmortem postings and as undergraduate students. I remember my forensic medicine professor, which is very, very clear in my mind, one condition which is known as the status thymolymphaticus, wherein he demonstrated thymus gland was lobed one. And that was the one, that is one of the very much common causes of sudden cardiac death. This is what I remember very well, maybe how many years now, almost 50 years back. Now, and I try to find out about this, and now I think it's not an entity at all. So can I know your any views on this status thymolymphaticus? Is it still considered as an entity, a cause of a sudden cardiac death?
No, actually, you are very right. In the olden days in 1970, they thought there was a relationship, And there was a association that sudden cardiac death occurs partly because of some sudden things of the thymus. But after that, we have not been able to associate ourselves with any of the episodes of this thymus gland. But of course, immune complexes are responsible for a large number of sudden cardiac deaths because of inflammation. And now, with the biomarkers available, we may be able to pick up many of the, as I told you, the cytokines or the inflammatory syndromes. So we may still come back to thymus, we never know. I'll tell you one more thing about Sethuraman. He's still listening, I think. He told me that, is he there or he has gone? Setu is gone. But anyway, it doesn't matter. So he said colchicine will come back. Colchicine will come back. Colchicine has got a role to play in anti-inflammatory. I don't know if you remember, Setu, what you told. And it has come back. Colchicine as an anti-inflammatory drug for acute myocardial infarction. There are now 2 big trials, and a small dose of colchicine will prevent ventricular arrhythmias, will prevent limit the myocardial infarction. So colchicine has got a role. So like that, it may come back to inflammation. In fact, inflammation is here to stay. And we know very well that there is a drug called canakinumab, which is an anti-inflammatory drug, which is now used in myocardial infarction. So it may play a role in sudden cardiac death. In fact, they say that the omega-3 fatty acids prevent inflammation and prevent sudden cardiac death and atrial fibrillation. But talking about autopsy, the thing of sudden cardiac death came from the autopsy. You know that myocardial infarction is coagulation necrosis, and then the brain has colliquative necrosis or lipid. But sudden cardiac death is a very peculiar necrosis, which is called as contraction band necrosis. It's like a stone heart. The heart stops in systole. A lot of calcium goes inside the cells, and it stops in systole. So that's how a lot of pathology work has also been done in complete sudden cardiac death.
Thank you, sir. May I invite Dr. K.R. Sethuraman, sir, to say some words. Please unmute yourself.
Very elaborate and comprehensive talk as usual by JBC, and he had dumbed it down so that non-cardiac specialists also can understand what is going on. I remember when he was in the final year, at that time, one Stokes-Adams syndrome case was admitted in the ward. Almost many patients, many people came and saw, because he gave classical history of recurrent fainting spells, and then we recorded ECG that time. He was connected, and one of the fainting, and we showed short ventricular tachycardia, and he will recover by himself. So he was saying that for the past few years, maybe 5-10 years, he was a village headman. He used to get this and fall down. He will wake up and then walk off. They thought it was some kind of minor epilepsy and left it. But here we diagnosed Stokes-Adams, and then he was advised pacemaker, which he was not willing. He said that it's okay, I fall once in a few days, and I always God takes care of me. But then the unit consultant was hell-bent on making him fit a pacemaker, because it will be the first pacemaker, I think, in his unit to be fitted for a patient. He was keen on getting that thing. So Professor Mansharamani asked the registrar to scare the fellow, saying that this can happen, that can happen, and they gave all the risks of sudden cardiac death and all that. And so I was intern that time. So when I wrote the discharge slip and gave, he went against medical advice. Anyway, I gave a discharge. Then he said that I was always confident that I will wake up and I will walk again after a short gap. Unfortunately, your big doctor has scared me now. I don't know. Next time I fall down whether I'll wake up and God will save me or not. You know, he was quite sad and depressed and upset that he couldn't afford a pacemaker. He went out to Gorimedo bus stop to catch the bus. He had a stroke sedum attack there and then he died. They wheeled him. I was on duty that day. Casualty call came, somebody has come with cardiac arrest. Go and see, it is the same guy. So I believe it's one of the, what you call as voodoo death, or hex death. So sometimes we scare the people, they react badly and yeah, they have this hex effect. I'm a very strong believer on that. That's why when you give scary prognosis and all that, we must water it down and also give the possible benefit of what we do and also balance it. Otherwise, just by our words itself, we can harm them. That case is still etched in my mind, 1973. Thank you. 1974, I think. 1974.
In fact,
Thank you, sir.
I can recollect one or two more cases which Sethuraman had diagnosed from clinical itself. We were one patient was there. He was from Nilgiris actually, and short fellow, and he had all the episodes. He had some stroke symptoms, but mainly he had conduction abnormality. So we were wondering what sort of. We used to give him some temporary pacemaker, this, that, and all that. But he said this is endomyocardial fibrosis, and we didn't believe it because we have not seen a case of endomyocardial fibrosis at all those days. After that, it became popular. So finally, he died in the ward, and I took a lot of effort, including giving the relatives ambulance because I wanted autopsy. And the autopsy showed endomyocardial fibrosis. So it was a diagnosis which was based on clinical, but it proved to be correct. So that is the.
The credit goes to Bala for doing partial autopsy. He was interned that time. I said, somehow get the heart out so that we'll get the diagnosis. We were following him up for quite a few months, a few repeated admissions.
This same thing, the status thymolymphotic is also found there. Our dean had correctly said sudden cardiac death has been reported. In fact, it's called as diathetic anomaly. It's called. I don't know what it means. Sudden status thymolymphotic is called diathetic anomaly. Maybe I have to look up what is diathetic anomaly, but it occurs in children. It occurs in children. So it may be still there. We are not sure whether it is existing.
Dr. Bala, I just want to ask a question for students' benefit. If the severe hypokalemia sometimes happens post-surgery and all that, that is a cause for ventricular tachycardia. What is the method of rapidly correcting the potassium without harming the patient? Is there any way?
Actually, we used to give short, small IV injections of 2 ml of KCl, not more than 10 milliequivalents to correct it. But we found that in the process, sometimes it leads to hyperkalemia and worsens the episode. So best is still give the rapid infusion of potassium. But now we give, before potassium, we give magnesium because we know magnesium and potassium are going together. So that can be given a little faster. So we give magnesium and then we give potassium so that it gets corrected quite quickly.
Okay.
But still, I think IV is better. IV infusion is better than giving bolus doses of potassium infusion.
Okay, then thank you, Dr. Maha and Kotur, for inviting me.
Yes, sir.
Thank you. Thank you for coming.
Thank you, sir. I think we had interesting queries and discussion. Before
I want to ask, sir, not question, one observation. Actually, Dr. KRS might also remember this when we had a discussion about what Dr. Bhatt raised, whether we should train everybody in automatic defibrillator. But if you see the ACLS course, there is a component of automatic defibrillator which is involved in both ACLS as well as in BLS, that AHA thing. But when we ask the students, that is people who finish the course, the exiting interns, we asked them, do you know how to perform CPR and do you know how to perform defibrillation? Most of the students said that we did not know how to do defibrillation. they are not actually connecting the automatic defibrillator with the paddle defibrillator what we have. So that is what was the issue. No, the automatic defibrillator, even though they are trained to use that, they don't connect it to what we use, the traditional paddle defibrillator. That is one observation which we found in the exiting students.
Thank you, sir. I think we had a encouraging discussion and very elaborately discussed about sudden cardiac death. Before I wind up, one more small question is left over by any change. Is there
Sodium.
any change in the serum sodium level in
Sodium,
Brugada
yeah.
syndrome? Brugada syndrome, which you have mentioned, whether there is any change in the serum sodium level?
Yeah, actually, the types of Brugada syndrome depends on the sodium. One type is sodium channel. That's why it's called SCN5A. It's a sodium channel defect. So you can sort of prevent it by administration of sodium. Hyponatremia can precipitate long QT, although it is hypokalemia, which is traditionally having a long QT. But one type of long QT syndrome can be treated with sodium administration, although, of course, it's only for that moment you can tide over the crisis by hydration and by giving sodium. It's a sodium channel defect, just like you get in other places. In fact, one of the drugs which is now commonly used, called ranolazine, it's used in angina management, ranolazine. It's a late sodium channel blocker. So late sodium channel blocker, it can be used as an antiarrhythmic drug, especially in the long QT syndrome, LQT3.
Thank you, sir. That query was from Dr. Vishnu sir. Dr. Sir, you want to say something?
Mute, unmute.
Sir, please unmute yourself, sir. Dr. Bhatt, sir.
Yeah, it was not getting unmuted. Maybe you have locked it. I used to always, I am continue to admire Bala, one for his knowledge. Second is in simplicity and always being cool. So these are probably the best quality I'm seeing in addition to his vast knowledge. And Dr. Sethuraman, of course, he made him a cardiologist, but of course, he impressed me also with the ECG and other things, but I didn't take up cardiology, of course. Individual interest vary. Sethuraman used to teach us echocardiography, ECG, and computer. He used to bring one broken computer and make us all sit and teach. Before we used to have computers, that Bala told same thing. So it was very interesting. He was a very good teacher. So I'm nice to see Sethuraman along with Bala. Both are very knowledgeable.
He called me to Malaysia. I didn't go. He said, I said, I don't have passport. So I'm not coming to Malaysia.
So thank you very much, Bala. So, yeah, Deepa, you can.
Thank you, sir. I thank Dr. J Balachandar, sir, Dr. KRS, sir, Dean, sir, Dr. Vishnu sir, and Madam. I thank all the participants for your patience listening of this session, sharing the knowledge and experience from the experts. Thank you, one and all. Next week, we have another interesting and important topic of monitoring in ICU by Dr. Narayan, Professor of Pediatrics from JIPMER. It will be our 46th episode, I think. I welcome you all for the next session. I'm waiting for the next session. Thank you once again. Logging off, Dr. S. Deepa,
Small request from my side,
yes,
that if you can give me access to the other people's session, I can attend also. I mean, I would like to attend.
I think
Sure,
the
sir.
same
We'll
link will
send the
be
names.
for all.
Huh?
All
Glad
of
you
us
could
made
link.
same link.
I wanted to attend Matthew Cherian because Matthew Cherian and we worked together in JIPMER. We had the foundations of this thing, cath, angio, everything. And we were there. So like that. If there are interesting sessions, I don't mind attending.
I had sent the link actually. I think you might have seen after the talk was over.
Yeah, correct, correct. Yeah.
Also
The
for
same
all,
link will work for next week also.
sir, that is what I want to say, that we have been conducting this webinar using the same link for the last 46 weeks, sir. It's the same meeting ID, it is the same password, it is the same link.
Fine.
We don't change it because we want people to come recurrently for the sessions. So that is how we have framed these webinars.
Few of our classmates were also there, I think, listening.
Yeah, Pushpa said work.
Okay, yes. Shall I wind up?
Yeah.
Thank you once again. Logging off Dr. S. Deepa, Member Secretary Scientific. We'll meet once again next Friday, 2:45 p.m. at the next FFF webinar, episode 46. Thank you once again.
Thank you.